Okay, let's look at the uh, thyroid and adrenal in thyroid gland and adrenal gland in this lecture. So here we have the um, hypothalamus, and the hypothalamus is going to send some sort of signal to the pituitary, which is here, and then we have the thyroid gland here. So some sort of stimulus, whether it be cold or stress or any type of stimulus, is going to tell the hypothalamus to increase the secretion of thyroid releasing hormone. So thyroid releasing hormone is going to go to the anterior pituitary and tell the anterior pituitary to push out thyroid stimulating hormone. So now thyroid stimulating hormone is going to hit the receptor site on the thyroid gland, and it's going to tell the thyroid gland to push out primarily thyroxine or T4. I know it says T3 and T4, which is true, but T4 is the predominant hormone. T4 is thyroxine. T3 is called triiodothyronine. It's when you have 4 iodines attaching to tyrosine or 3 iodines attaching to tyrosine. So thyroxine will then go to the liver and get converted to T3. And again, it's selenium dependent. You need fat um, as well on the thyroid for the T4 to be produced, but at the level of the liver, T4 gets converted to T3, and that is selenium dependent. So it increases metabolism at the target cell, and then eventually there'll be a negative feedback loop that goes up to both the hypothalamus and the pituitary, and it says, okay, shut down, job is done. The the thyroid can be hyperactive or hypoactive. Whenever the thyroid is hyperactive and you get an increase in this metabolism, we call it a hyperactive thyroid. When it's working under, then we call it hypoactive thyroid. So just want to show you that T4 gets converted into T3, and just want to show you some of the things that can influence them. Um, so factors that can inhibit the proper production of T4, stress, infections, trauma, radiation, certain medications, fluoride, which is an antagonist to iodine. There are toxins like pesticides, mercury, cadmium, and lead. And there are certain autoimmune diseases like celiacs that can impair um, proper production of T4. Now, what are some of the factors that increase the conversion of T4 to reverse T3? Now, T3 is metabolically active. It's what's going to increase your metabolism. Reverse T3 is the exact opposite of T3. They look identical. It's like taking 2 pencils and you flip one pencil upside down. Okay, that's reverse T3. And reverse T3, all reverse T3 does is it competes with T3 by binding to the same receptor site. So you may have normal T3, but if you have more reverse T3 in relationship, then reverse T3 makes it to the receptor site and it does nothing. Reverse T3 just blocks it. So the effects of T3 don't work. And this is why there's so many subclinical um, thyroid imbalances where someone has all of the symptoms of a hypoactive thyroid, but because T3 is normal and thyroid stimulating hormone is normal, if the endocrinologist never checks for reverse T3, they could be missing a lot. And a lot of endocrinologists don't. This is more of a functional analysis. Stress, trauma, low calorie diets, inflammation, infections, toxins, liver or kidney diseases can increase reverse T3, competing with the same binding site. So now you have decreased metabolism, you have a hypoactive thyroid. Things to support T4's conversion to T3. There is selenium. We said that's important. You need iodine, zinc, tyrosine, vitamin E, B2, B3, B6, vitamin C, and D. So healthy nutrition is really important for healthy thyroid function. Factors that convert T4 to T3, that's your selenium and zinc. T4 to T3 conversion takes place primarily in the liver. And factors that can improve the cellular sensitivity to T3, vitamin A, exercise, and zinc. Now, I put this up here because I wanted to show that there are some medications that can affect thyroid function. And one of them is an antibiotic that's in the family of the fluoroquinolones. Um, this is like Cipro, ciprofloxacin, Cipro, levofloxacin, Levaquin, um, moxifloxacin. Is a whole bunch of these, and the side effects can include sudden severe insomnia, hypnic jerks, tendon and cartilage tears, brain fog, weird sensation like bugs, creepy crawly sensation. Um, so there is a major issue. When you combine quinolone antibiotics with T4, it can lead to reduced absorption of the thyroid medication and cause changes to thyroid stimulating hormone. Okay, so have to be really, really careful with certain antibiotics, and this is why the doctor has to take a good case history, and that a good pharmacist needs to keep track of what drugs you're taking, because sometimes there's a contraindication to them. Okay. Goiter is when there is an enlarged thyroid gland. An endemic goiter is when there's a hypothyroid condition in regions with low iodine levels in soil and food. Now, this doesn't happen so much here anymore because a lot of food, especially with salt, right? Salts are iodized. So this is not so much an issue here, but in certain countries, you can still see these goiters as a result of having too little iodine. Because remember, iodine is needed for healthy conversion of T4 into T3. There are goitrogens. These are certain foods that contain elements that block the synthesis of T3 and T4. Cabbage, turnips, and even certain medications such as lithium. Toxic goiter results from an hyperactivity of the thyroid. So something that's creating an excessive stimulation from TSH, thyroid stimulating hormone. So here is a person that has an enlarged neck because the thyroid is full. There's low blood levels of T3 and T4 that stimulates the hypothalamus. It tells the hypothalamus to release thyroid releasing hormone that goes to the anterior pituitary, and thyroid stimulating hormone is released, and thyroid stimulating hormone stimulates the thyroid gland to push it out. And you get increased TSH leads to this constant hypertrophy and increase in size, creating a goiter. Okay, this is what it looks like when I'll always have my patients extend their head up and back to see if it brings out that fullness of the throat. An example of hyperthyroidism, hyperactive thyroid, is Graves' disease, and this is an autoimmune related disease. There's hypermetabolism and increased stimulation of the sympathetic nervous system. So they get this very fast heart rate, tachycardia. Metabolism is much, much faster, so there's going to be this increased in body temperature, increased in sweating, soft, silky hair and skin. They're going to start to lose weight. They just, they'll say, no matter how much I eat, I just can't put on any weight. Insomnia and hyperactivity. That's hyperthyroidism. Typically, you'll see this condition called exophthalmos, which is this present of this protruding eye. It looks like a staring eye. There may be decreased blinking and eye movement, and this is going to result from this accumulation of these polysaccharides that start to accumulate in the back of the eye, increasing the tissue mass, pushing the eye out a little bit. So this is exophthalmos, this is exophthalmos, this is exophthalmos, again seen with hyperthyroidism, usually Graves. Now there's hypothyroidism, a common condition, another common condition called Hashimoto's thyroiditis. This is hypoactive. It's a severe form in adults. You'll start to see this myxedema, which is puffiness under the eyelids. You can also see puffiness in front of the legs and discoloration in front of the legs. We call this myxedema. In young children, it needs to be diagnosed, especially in a mother as well, when a mother is pregnant, to make sure that the baby's development is not affected, because if a mom has a thyroid imbalance, it can result in cretinism of the baby. I'll show you what that looks like. There's short stature of the baby, severe cognitive deficits. So you start to see this type of appearance where there's puffy eyes, the child is really uninterested, you get this large, thick tongue, macroglossia, the child is just uninterested expression. This is cretinism, typically because mom had a thyroid imbalance, and so does the child. Here is the signs of myxedema, the puffiness under the eyes, also with thyroid imbalances, especially with hypoactive thyroid. You can see the lateral 1/3 of the eyebrow breaks down. It's a classical sign with dry hair that's coarse and sparse. And then here you start to get this discoloration in the lower legs. It's called pretibial myxedema. Some of the other clinical manifestation, goiter, if the cause is endemic, iodine deficiency, there's going to be an intolerance to cold, increase in the body mass index, lethargy, fatigue, decreased appetite, again, the myxedema in severe untreated hypothyroidism. There'll be non-pitting edema in the face, the thickened tongue. Non-pitting edema is like, pushing with the thumb along the tibia, and then when you remove your thumb, pitting edema is when you still see the depression of your thumb in their skin. That's more of like kidney issue and heart-related issue. Non-pitting edema is when you can put pressure and you move away, and it does rebound back. Okay, and myxedema coma, acute hypotension, hypoglycemia, hypothermia, and this can result in loss of consciousness. This becomes life-threatening if it's not treated. Okay, here are some of the comparison between hypoactive thyroid and hyperactive thyroid. With hypo, T3 and T4 is low. With hyper, it's much higher. When hypoactive thyroid is present, metabolism slows down or it speeds up with hyperactive thyroidism. With a hypoactive thyroid, there could be the presence of an endemic goiter, and in hyperactive, it's present with Graves' disease. The skin will be pale, cool with edema with hypoactive, and it'll be flushed and warm with hyperactive. With the eyes, you get that exophthalmos with Graves, but you don't get it with hypoactive thyroid. The cardiovascular system slows down. You get bradycardia with hypoactive, and with tachycardia with hyperactive. With the neural system, hyperactive is restless, nervous, tremors, otherwise always tired, lethargic, and slow with hypoactive. The body weight, with hypoactive, they tend to increase, but their appetite slows down. And with hyperactive, they're very thin, but they keep eating, and they can't put on a pound, right? This is the person with hypoactive. I don't even eat and I gain weight. And here's the person with hyperactive. I eat so much and I can't put on a pound. Let's review the adrenals. So here is the renal. The adrenal, aka suprarenal, is above. The adrenal cortex is on the outside. The adrenal medulla is on the inside. Stress. We've heard stress can kill, but there's some good stress and there's bad stress. So eustress is helpful. Everyday stress, it prepares us to meet the challenges of life. And then there's distress, which is a harmful stress that can be pretty damaging to people. We know about the fight or flight response, which is the first stage of the stress response. It's a sympathetic response. The resistance reaction is the second stage in the stress response. It lasts longer than the flight or fight response. And if it lasts too long, it results in a condition called adrenal exhaustion. Adrenal exhaustion. So here's the hypothalamus, here's the pituitary, and here's the adrenal. On the right side, you got the adrenal cortex, and on the left side, the hypothalamus sends signals to the spinal cord from the level of T1 to L2, and it leads right to the adrenal medulla. So in the adrenal medulla, you have the catecholamines, norepinephrine and epinephrine. And when that gets pushed out, you get that sympathetic response. Increased heart rate, increased blood pressure. The liver starts to break down glycogen into glucose, so blood sugar rises. You get the dilation of the bronchioles. You get the increased metabolic rate. Here, the hypothalamus sends signals to the anterior pituitary. It pushes out adrenocorticotropic hormone. It goes to the cortex, and you push out glucocorticoids, which is cortisol, cortisone, corticosterone, and then mineral corticoids, which is aldosterone. The glucocorticoids, look what's going to happen. Proteins and fats are converted to glucose or are broken down to energy. You get increased blood glucose. You get high blood sugar. You get a weakened immune system. When aldosterone is pushed out, you get retention of sodium. Again, when you hold on to salt, you hold on to water and blood pressure goes up. So in terms of a short-term reaction, the adrenal medulla activating the sympathetics with norepinephrine and epinephrine, you're being chased by a tiger or a lion, you want this to happen. When you have stress for a more prolonged period of time, this happens, and again, increase in blood pressure, increase in blood sugar. Now you have stress for a long period of time, high blood pressure, high blood sugar. Can you understand how stress kills? Okay. Pheochromocytoma, this is a benign tumor of the adrenal medulla. So now you're pushing out norepinephrine and epinephrine, increasing the sympathetic response. So you get headaches, palpitations, sweating, and anxiety. So when you look at pheochromocytoma, if we take the first three letters of pheo, P-H-E, P for palpation, H for headache, and E for episodic sweating, which is diaphoresis, that's a good indication. Or we could say there's 5 H's: hypertension, headache, hyperhidrosis, right? Hypermetabolism, hyperglycemia. Again, this is what happens when there's a benign tumor of the adrenal medulla and you're activating the sympathetics. Cushing's syndrome, we're going to look at Cushing's and then we'll look at Addison's disease. These are both diseases of the endocrine system that involve cortisol. It's whether you're pushing out too much or too little. In Cushing's syndrome, you're pushing out an excessive amount of glucocorticoids, cortisol, cortisone, corticosterone. That could be, and remember, this is the adrenal cortex now. So there could be an adrenal adenoma, a pituitary adenoma. There could be ectopic carcinomas, iatrogenic conditions, simply the administration of glucocorticoids to the body. This is going to create a change in the person's appearance where they have this moon-like face. It's called round face. They have truncal obesity with fat pads between the scapula, creating this Dowager's hump, or a hump right on the back of where C7 and T1 is. They call it a buffalo hump or Dowager's hump. Cortisol tends to create more fat accumulation around the belly, but cortisol breaks down proteins. So you get thin legs, thin hair, fragile skin, and you get purple striae on the skin, these stretch marks of the skin called purple striae. So here are the purple striae, here's the round face, here's the Dowager's hump or the buffalo hump here at the base of the neck. It's C7, T1, and again, purple striae. This is Cushing's syndrome. The clinical manifestations, you're going to get retention of sodium in water, suppression of the immune system, stimulation of the red blood cells, emotional lability and euphoria, increased catabolism, right? You're breaking down bone and proteins, delayed healing, and increased insulin resistance and possible glucose tolerance. So here's another picture where you get the buffalo hump, the fat pad here, also known as Dowager's hump, thinning of the hair, you get the round face. Hirsutism, we didn't cover this, but this is when you get hair in unwanted places, hirsutism. There's truncal obesity, purple striae, thinning of pubic and axillary hair in women, ecchymosis, again, that looks like little broken blood vessels, impaired wound healing, fragile skin. Same thing here, the round moon face, you get the purple striae, you get the high blood pressure, thinning of the skin, the buffalo hump or Dowager's hump, you get the thin arms, you get the thinner legs, poor wound healing. Now with Addison's, this is the opposite. This is where you have deficiency of the adrenocorticoid secretions. This could be an autoimmune reaction, which is quite common. The adrenal gland may be destroyed by hemorrhage as well, or some sort of infection. Either way, decreased adrenocorticotrophic hormone. This decreases blood glucose, inadequate stress response, fatigue, weight loss, frequent infections, hypotension due to the decreased blood volume, high potassium levels, and here we need hormone replacement therapy for sure. Okay. This compares both Addison's to Cushing's. So Addison's, you have the deficit of the corticosteroids, and in Cushing's, you have the increased cortisol. There's high risk of infections to both. There's poor stress response in both. With Addison's, there's weight loss and fatigue. With Cushing's, right, that's the moon face, the buffalo hump, the trunk is obese, you get the thinner limbs, osteoporosis. So here you have thickening of the entire body with the exception of the limbs, and with Addison's, weight loss. Don't forget you get this purple striae with Cushing's and the bruising of the skin, high risk of infections if the skin becomes thinner, that primary line of defense. You get hypertension with increased cortisol. When there's decrease, you get hypotension and fainting or syncope. With Addison's, you get hyperpigmentation of the skin. And with Cushing's, just fatigue, weakness, and delayed healing.